Hello, welcome to another video. Following on from the previous video I did regarding the MRI of the knee, I've been asked by a couple of my colleagues to make a video regarding the interpretation of ankle MRIs. So we are here. We are going to make a video regarding MRI ankle interpretation. Now, this video is going to be quite geeky, so if there's any patients watching this, you may not want to watch this unless you're really interested in the foot and ankle, which you should be because it's an amazing structure. But this is really designed for health professionals and medical professionals. Three things that I need to talk about before I talk about the interpretation of the MRI. Number one, we as podiatrists, we don't diagnose based upon MRIs, X-rays, or ultrasound. We use this to aid our clinical diagnosis. That's very important. Number two, I send quite a few patients off for MRIs because that's the kind of cohort I'm seeing. I'm seeing a lot of athletes, professional and recreational. So I get to view them quite a lot. And it takes about 10 to 15 days for the radiographer's report, but I get the images straight away, which is why I have a lot of practice trying to guess the diagnosis, and that's how I've learned. So I would encourage all my colleagues to, if you are seeing MSK patients, to, if appropriate, send them for a form of imaging, and then try and learn from that, from those images. I mean, the first time you ever did an injection, remember how scared you were, and then after you've done 10,000 or 500,000, you've got really used to it, and then you don't really think about it. It's the same thing when it comes to imaging. Don't be too daunted. Once you get used to it, it won't feel so alien to you. The first time I ever looked at ultrasound, I thought I could see fishes swimming because it was just alien to me. It took me a long time. And similarly with MRIs, X-rays are probably a lot easier to read, actually. That's the second thing. Number three, I am a podiatrist. I am still a student even after all these years. So if I make any mistakes, please forgive me in the next 10, 15 minutes. Okay, let's start. This is an axial view of an ankle. So going straight down, you're looking at the ankle straight down. The way I look at MRIs is I look at bones, bone marrow, articular surfaces, ligaments, tendons, muscles, and then other structures. With the ankle, we're looking at something like the sinus tarsi, and there's a couple of other structures that we look at. It's a lot more complicated than the knee, actually, which makes you realize how wonderful our profession is. So, first of all, hope you can see that. That is the tibia, and that is the fibula. That's the two bones. I'm going to go back over all the structures in a minute, but let's just go over the bones a little bit. And then we'll go back to it. When we go further down, we come to the tibial plafond here, which literally just means ceiling in French. I wish they had some Arabic words for this as well, but this is a discussion for a different time. Then that is the tibial talar articular surface. Then we get three distinct structures. That's the medial malleoli, talus, and lateral malleolus. Then you're seeing the talus a bit more, the neck of the talus, and you'll see the navicular there. That's the calcaneus. That there is the retrotrochlear eminence of the calcaneus. You'll see a bony protuberance there. That is actually the perineal tubercle, which will be very important when we speak about the perineals a little bit later. Here we have the cuneiforms 1, 2, and 3, and then you come to the heads of the metatarsals. Let's not forget the cuboid, which is very, very important. Let me go over all the structures that you can see at this level, because it's very important that you understand. As I said before, that's the tibia and fibula. Tom, Dick, and very nervous Harry, so tibialis posterior, flexor digitorum longus. These are all the neurovascular bundle, so the veins and the artery, and the nerves, and we've got flexor hallucis longus. Look how low down the muscle belly comes. This is the Achilles tendon. That little dot there Guess what that is? That is the plantaris. It's a very small muscle. Some people, they actually rupture the Achilles and they can still function because of the plantaris, goes to show. We have got the perineals here, perineus longus and brevis, this black area here. They look like they've merged here, but when you go further distal, they tend to separate. Tom, Harry, and Dick, so tibialis, anterior, extensor, hallucis longus, etc., digitorum longus. That's the retinaculum that is encompassing it, and we've similarly got a retinaculum here and here. There are other structures here, but I'm not going over everything because this video will take far too long. Okay, so when we go down, let's look at some of the ligaments first, okay? Now, the first ligament, or the first set of ligaments, is the syndesmosis. There are 3 ligaments within the syndesmosis. We've got the anterior inferior tibiofibular ligament here. We've got the posterior inferior tibiofibular ligament here, and we've got the interosseous tibiofibular ligament there. That's very important structures here, and you can see them further down here and here. The next lateral ligaments that we need to look at is the anterior talofibular ligament, which is just here, posterior talofibular ligament. You see it's actually quite a lot more thicker, isn't it? This one gets injured a lot. The ATFL is something that I think I see so many athletes, and you can, with that damaged ATFL, there's many people that function very well without an ATFL. So that's very important to understand. Where the calcaneofibular ligament is actually further down, and it's just behind the perineals, and it just runs there. What other ligaments should we look at? So let's look at that is the calcaneonavicular ligament, which is a very important ligament. On the medial aspect, okay, that's a deltoid ligament. Now, it's viewed much better with other images, and I'll show you why a bit later. When we come further down, see that there? That's the spring ligament. Very, as everybody knows, is very important. Very, very important. That's some of the major ligaments, and you can view a couple of the other ones in the other images, which we'll briefly go through. Let's look at the perineals. Okay, so now, if you look at the one that's closest to the bone, that will be perineus brevis, and you'll see them separate just there. There you go. Now, the perineus brevis here will go and attach to the outer aspect of the base of the 5th metatarsal, just there. So if you ever get patients with complaining of pain in that region, it could be the insertion of the perineal brevis. This perineus longus tendon, this bad boy here, this bad boy shoots across the cuboid there and attaches to the first MTPJ, base of the first met. Those are the 2 perineals, and there's loads of problems that can occur within those 2 structures. Tibialis posterior, you can see it actually attaching to the navicular there, and it shoots off in other directions also. And the flexor digitorum longus and flexor hallucis longus, which you can track from there. And there's actually a bit where they cross, which is called the master knot of Henry, or the knot of Henry, depending on who you're speaking to. That was a brief run through, and I haven't gone through the tibant and other structures. But generally speaking, if I'm seeing a patient with a MRI of the ankle, I'm looking at the lateral ankle quite a bit. I'm going to briefly go through some of the other images. Now, this is the coronal image. So you're looking at the ankle from the front. Why I think this is important is, let me just move this over here so it's a bit. Now, that there is a deltoid ligament. It's got superficial and deep fibers, and it comes very clear on the coronal image. And it's also very good to look at the articular surface here. Obviously, we're looking at bone marrow. We're looking for tumors, cysts, contusions. We're looking at articular cartilage. The ATFL comes here. It's quite a thin structure compared to the posterior tibial fibular ligament. and the calcaneofibular ligament is further down. It's a very thin structure. Syndesmosis I find very difficult to pick up on here. You can actually pick up the spring ligament on here as well. Further down, it is just there. I'm going to briefly go through the sagittal plane, which is brilliant to view. If I can get it up on screen, insert layer, insert here. Okay, so now this is brilliant. So this is the tibialis posterior tendon attaching into the base of the navicular. That there is the deltoid ligament. And if I scroll further down, flexor digitorum longus, and you'll see bits of flexor hallucis longus, and you might even see the knot of Henry down there. If we come, let's view now. This is an awesome view. Okay, first of all, that's the Achilles tendon. That is the soleus. Kager's fat pad. That's where we do the high volume image guided corticosteroid injections for mid-portion Achilles tendinopathy. If you have a low-lying soleus, that can cause problems also. Calcaneus, talus, you can view, if I go here, you can view the posterior aspect of the subtalar joint there. You can go anteriorly, anterior aspect, and the middle part of it, that's the sinus tarsi. You'll see the plantar fascia just there. And that there, this bad boy here, that's the calcaneocuboid ligament, and it shows up beautifully, absolutely beautifully. This here, I'll talk about this a little bit. This is flexor hallucis longus. And look where, if you had an accessory bone, it would probably be here. It's your os trigonum. And it comes around and it goes in a process in the back of the talus where it sits. It's called a Steider's process. So if you have posterior ankle impingement, it's because of two reasons. Either you've got a os trigonum, or you've got an enlarged Steider's process, and it comes around and it shoots into that direction. That's awesome, isn't it? I love MRIs. There's loads more structures here that I could talk about. You can actually see the spring ligament, or parts of the springs of the spring ligament here. The sinus tarsi is also a very important structure to be able to examine. There's a fat pad. And if you go more posteriorly, that's the perineals, that's the fibula now, and you'll see where they split, which is going to be the perineal tubercle. And then you'll see the brevis attaching to the lateral aspect of the fifth metatarsal. It's quite hard to pick up the longus on this view all the way down. But that's the major things we're looking at sagittal. I find some of the other images easier to view, the ligaments on. I find this one slightly difficult to pick up the ligaments on. But there's a lot you can pick up on all three views. Now, briefly, let me just see if I've missed out anything major from these MRIs that may be of use. Now, there's a lot of structures that come into the cuneiforms, which we can spend a long time examining, actually. But the articular surface is very important to examine. Sometimes we as clinicians get lazy and we call it the cuboid syndrome. It could be the calcaneocuboid ligament that has got an issue with it. So it might be that, rather than the cuboid itself moving out of place, which we know physically that's just not happening. It's not possible. It ain't going to sublux. But there could be scar tissue around that area, actually, for various different reasons. But yeah, I think I've covered a lot of the major things in this whistle-stop tour in 15 minutes. Now, please, by no means is this a comprehensive guide to viewing a ankle MRI. I could spend a very long time talking about ankle MRIs, but I didn't want to make it too technical. I would encourage all my colleagues, learn. The more you learn, the better it is and the better you manage patients. And thank you for watching, and I hope you found this helpful.